Moving on to the last session of Diabetes Today 2020, it is Future Diabetes. For chairing the session, I would like to invite Dr. Anand B. Nair, sir.
Thank you for this great opportunity once again.
Okay,
The last session of the marvelous conference, Diabetes Today 2020. It has been a totally novel experience for all of us because we were going digital for the first time. But the response session after session has shown that there has been a great success till now. So for the final session here, the recent advances in diabetes or future diabetes, as it has been rightly termed, we have got three very eminent speakers, all of them my friends from Trivandrum Medical College. So without wasting much time, let me introduce the first speaker of the day, Dr. Anand M. Pillai, who is a consultant interventional cardiologist, Anandaburi Hospital and Research Institute. And he would be addressing the topic, newer therapies to address dyslipidemia. So without wasting much time, straight away handing over the mic to my dear friend Anand, who is sure to enlighten us with great wisdom and in a highly entertaining way. Over to you, Dr. Anand.
Thank you, Dr. Arun, and thank you, the team, for the opportunity.
Okay, very good. So we'll talk about dyslipidemia beyond statins, touch upon CETP inhibitors and PCSK9 inhibitors. So the first thing is we know that statins work very well for patients with vascular disease. Even with diabetes, you're able to bring down the LDL cholesterol to a very reasonable level to prevent events. So is there any further role for an additional anti-dyslipidemic agent is the first question. So if you see here, although statins are very effective, there is still some degree of remnant CV risk, which could still be further addressed. So we are pushing our science and technology these days to come to the best that we can achieve. Okay. So what are the current limitations as far as we know? We know that statins work well and they bring down LDL by almost close to a 50% level. But there is still another 30% reduction in in LDL levels, which can be obtained. A second thing, the higher the statins goes, the incremental benefit of reduction of LDL is less. We know about the common side effects of statins, and sometimes there can be poor tolerance as well. So we'll talk about two relatively new molecules, CETP inhibitors and PCSK9 inhibitors. CETP inhibitors are relatively new, and they're still kind of in the clinical trial stage and not in clinical use. So I'll briefly mention about them. CETP stands for cholesterol estase transfer proteins, which has a major role of transferring triglycerides and cholesterol esterase between the VLDL and liver. And the CETP inhibitor, essentially what it does is to increase the HDL in our body. We know that HDL is the good cholesterol, which we want it to be higher. And here you see that CETP inhibitors can improve your HDL from a baseline level of 40 to almost 100. And along with that, there can be a reduction in LDL as well. But unfortunately, most of the trials with these inhibitors have not stood the test of time. Some of them had a higher death rate. Some of them did not show any clinical benefit. So although numerically the HDLs were increased, there was no clinical benefit, except for the last molecule that you see here, which showed some modest benefit. But even the manufacturers were not confident about the overall performance of the drug and it is being stalled. As far as I know, there is none in clinical use. There are probably some trials going on. So the take-home message is, although we know that HDL is good cholesterol and elevation of HDL is good, there has not been a clinical benefit by the increment in HDL is the lesson that we take from the CETP inhibition. Let's move on to PCSK9. Again, a relatively new molecule. I'll talk about some basics as it may not be familiar to most of the audience. So what is PCSK9? It stands for pro-protein convertase subpillicin type 9. It is a protein which is seen in the circulation. Let's go back to a little bit of cholesterol metabolism basics. This blue thing that you see here is an LDL receptor seen on the surface of the liver, which takes the LDL molecules into the liver and thereby reduces the blood level of LDL. And this is part of the normal cholesterol metabolism. And these receptors are recycled to the surface. So what PCSK9 protein does is to bind to these receptors in a normal fashion and metabolize them and kind of maintain a balance of these receptors. So if these proteins are inhibited, there will be more LDL receptors on the liver surface, which will take in more LDL into the liver and thereby reduce the LDL number in the circulating blood, which is what PCSK9 inhibitors do, which is actually a monoclonal antibody against this particular protein. And once this protein is bound, it is not able to bind to the LDL receptors on the liver surface. So there are more receptors, more intake of LDL into the liver, and the blood levels of LDL will come down. So PCSK9 inhibitors, and they're supposed to be very potent even beyond statins. Patients who are already on statin with the LDL which has come down to less than 100, they can bring down an LDL down to even in the 30s and 20s. So it's like a super statin. And on top of the LDL reduction, it also has several other favorable roles, including reduction in ApoB, improvement in HDL, and reduction in triglyceride. The key thing which all of us need to know that this is a very expensive therapy. This is a subcutaneous injection given once in 2 weeks, and one injection will cost you 17,450. So a monthly expense of 35,000 and a yearly expense which can go into the lakhs. So that is a key thing which all of us need to be aware of. So it's a very expensive therapy, and let's see if this money is worth spending. So who are candidates for PCSK9 inhibitors? I have listed them here. Let's come to number 2. Number 2 are patients with familial hypercholesterolemia, particularly homozygous hypercholesterolemia, which tend to have a very high abnormal LDL. And these patients will benefit because there is a limit to which this can be brought down as far as the statins are concerned. And heterozygous familial hypercholesterolemia patients will also benefit. Then established cardiovascular patients who are high risk because of recurrent MI or their LDL levels cannot be brought down to target with statins are the patients who will potentially benefit from these drugs. So how much lower do you want the LDL to be? So our guidelines had gone to less than 100. Now it's less than 70. Now the guidelines are even talking about bringing your LDL less than 40 in high-risk patients, which is what PCSK9 can do, as you see here. And there has been a linear correlation between LDL reduction and cardiovascular events. So this is the intravascular ultrasound study using a camera inside the coronary artery. And these drugs have been shown to physically decrease the atheroma volume in patients with coronary artery disease. 4-year trial was a key trial studying the PCSK9, the evolocumab molecule, which was studied in patients, high-risk patients who have already had MI, stroke, and symptomatic peripheral disease, and patients who are already on statin, and despite of which their LDL is more than 70, are the patients who were studied. And an impressive reduction of LDL from mean of 90. So a 90 to begin with is pretty good as far as CAD patients are concerned, and that is on the statins. And on top of the statin, the PCSK9 brought your LDL down to less than 40 or almost 30. And there was a statistically significant reduction in cardiovascular events, 16% relative risk reduction and a 25% reduction at 2-year intervals. The lower you brought the LDL, so less than 20, the risk reduction was even better. And patients who are higher risk but with higher number of MIs and recent recurrent events also benefited with lower events. Pertinent to our meeting, the diabetic subset of patients also, there was equally good reduction in LDL down to the 20s. And not surprisingly, the benefit was also better because in the diabetic population, the events were higher. So was the relative risk reduction, 2.7% as opposed to a 1.6 in the non-diabetic patients. There has been a lot of controversy asking about, well, if you bring a LDL so low, is it not going to cause adverse events? And interestingly, there was no safety concerns. So even with patients with LDL less than 20, did not have any adverse side effects. So where do we stand? We have a molecule which is able to bring your LDL down into the 20s and 30s and have been proven to reduce cardiovascular event in these patients. I'll come back to my summary slide and which patients this is benefited. So in one way of putting, if you can afford it, any CAD patients will benefit, and you'll have to shell out around 30,000 rupees a month or 4 lakhs rupees a year. It's a twice monthly injection taken subcutaneously, and has been a benefit in these patients. But a specific population who will benefit are high-risk patients who have recurrent MIs or recurrent multivascular disease despite statin, and despite statin, if their LDL is not less than 70 will benefit, and then patients with familial hypercholesterolemia. And not surprisingly, these have made it into the guidelines for the indications that I just talked about. Thank you.
Yeah.
So I think Dr. Arun can introduce Anusha. She being my batchmate and my very close friend, you can specially introduce Anusha to this forum.
Okay, definitely. So this is the second time I get this great opportunity to introduce Anusha to this august audience. Dr. Anusha is a consultant vitreoretinal surgeon at Shankara Eye Hospital, and she was an MBBS graduate from Trivandrum Medical College and did a post-graduation from AIMS New Delhi with gold medal. She has a lot of publications in in-text journals, and she's an expert in vitreoretinal surgery. So recent advances in the treatment of diabetic retinopathy is the topic which she is going to talk to us. Over to you, Anusha.
Thank you, Dr. Arun, and thank you, Dr. Sabeer, once again for giving me this opportunity. Feel really fortunate to be a part of this Diabetes Today 2020, and as Dr. Arun said, it's been a really new experience for all of us, and I congratulate the entire team for such a wonderful performance and such a great success. So the topic for today is the session is the what's new or the future in diabetes. So I'm here to discuss what's new in the management of diabetic retinopathy. What's new? That's not moving. 1 second. Yeah. So first of all, the diagnosis. Only if you diagnose, you'll be able to treat. So that's the importance of screening, and that's where the artificial intelligence comes in. So what's new in diabetic retinopathy is artificial intelligence. In collaboration with Google, they have formulated a deep learning artificial neural network which has been trained to detect even minor forms of diabetic retinopathy based on fundoscopic images. Now, it has achieved a sensitivity of around 75 to 96% and a specificity of around 93.4 to 93.9% in detecting referable disease. So once referred at peripheral centers, once labeled as a patient with diabetic retinopathy, they can be referred to future centers for further evaluation and management. Another is telemedicine. There are telemedicine booths set up in different hospitals when patients, even in the peripheral, even the rural villages, can access access ophthalmic care. So based on the features, I discussed this in my previous presentation as well. So this is what the artificial intelligence does. It classifies into mild, moderate, severe, and macular edema. And very severe forms like the proliferative diabetic retinopathy, the presence of new vessels, the presence of hemorrhage, and the presence of retinal detachment, which requires surgery, can also be deferred using artificial intelligence and sent for us to further management. So that was about diagnosis. So once we diagnose, the next step is to image. Now, how do we image and confirm the diagnosis or assess the severity of diabetes and also assess what treatment to give and when? So the first is a fundus fluorescein angiography, which is always the gold standard. Then came the optical coherence tomography, which is actually a sort of a CT scan of the eye, which shows the different structures of the eye. But what is new now in the imaging is something called an OCT angiography. Now, this OCT angiography, it resolves the vascular details which are not achievable by the conventional angiography, such as the deep and the superficial capillary plexus of the retina. So it is equal to the FA in ability to detect macular complications of diabetes, such as microaneurysms and new vessels, and it also shows the presence of decreasing capillary density, the branching complexity, and increasing vascular caliber. So the application in diabetic retinopathy, it shows macular perfusion, shows the new vessels, shows microaneurysms, which are all present in the different stages of diabetes. And the early detection helps us to monitor progression and also the regression following treatment. So this is just to highlight the importance of OCT angiography. So this is an angiographic image. The importance of OCT angiography comes up in patients pregnancy or in advanced diabetic nephropathy where we cannot inject the fluorescein dye. So this is a dye-less technique. It is just based on Doppler. So this detects the movement of the red blood cells and gives a picture which is very similar to that found on the angiography. So this is the angiographic image of the eye, and this is the OCT angiographic image. So there was this with the dye and this is without the dye. You can see that it is very beautifully delineating all the details that is picked up even on a fluorescent angiography. Now you can see here, this is again an angiographic OCT angiographic image, and this is the fluorescent angiography, and you can see that it has picked up much more than actually the angiography has picked up. Now this is again a comparison between the angiogram and the angioplex map as seen in the OCT angiography. Another last picture, you can see the same thing, which is exactly how it is in the fluorescent angiography. It has come up on the OCT angiography as well. So now for the imaging of diabetes, we can do away with the dye in many patients, especially in pregnant females and nephropathic patients, and get an imaging without posing them any risk. The next was the importance of the glycemic control. HbA1c was recently found to be, if it is maintained less than 7%, it reduces the risk of retinopathy progression by 50% in intensive glycemic control patients. Also, phenofibrate, it causes lesser progression of diabetic retinopathy and reduced need for laser. As far as the treatment of diabetic retinopathy is concerned, the laser was always the gold standard for diabetic retinopathy. Surgery was always there, but now in the modern era, the anti-VEGFs have become of paramount importance. The anti-VEGFs have now revolutionized the management of diabetic retinopathy. Intravitreal VEGF inhibitors are the first line agents to now treat something called a diabetic macular edema, which is the known cause for visual loss in diabetic retinopathy. So the growing use in use of advanced disease such as a proliferative disease reduces the progression, less likely to have surgery or laser. So if you screen a patient with diabetic retinopathy and if you find that the patient does have an advanced diabetic retinopathy, this is an option that you can probably prime the patient for, that instead of directly going for laser, which is a destructive procedure, the patient can also do away with an injection, which is an anti-VEGF injection, which has been the most frequently used being a ranibizumab, which was recently FDA approved for treatment of all forms of diabetic retinopathy. So these are the different forms and these are the different targets at which they act. So you have these VEGF agents, then you have a VEGF trap, which I'll be discussing subsequently, which is the latest molecule which has come up. Then you have the protein kinase C inhibitors and something which anacortive acetate, which is a steroid, which is used to inhibit the angiogenesis or the new vessel formation. So again, pegaptinib, these are some of the anti-VEGF agents that are available. The pegaptinib, which is now out of vogue, bevacizumab, the ranibizumab, and aflibercept. Bevacizumab was initially used for the treatment of metastatic colorectal cancer. It is not FDA approved for intraocular use. However, because it is cheap, we still use it. Ranibizumab has been FDA approved. It is an fragment of the bevacizumab, and finally now in the market is aflibercept, which is a slightly expensive molecule, but it is a fusion protein which binds to all the VEGF isoforms. So VEGF, it is a vascular endothelial growth factor, is responsible for the formation of new vessels in the eye. So that is inhibited by these molecules. So this ranibizumab specifically binds only the VEGF-A, whereas the aflibercept not only binds VEGF-A but also VEGF-B and also the platelet-induced growth factors. Now the anti-VEGFs, as I mentioned, they constitute an early and regular anti-VEGF treatment and can halt and sometimes even reverse diabetic retinopathy. Bevacizumab, I mentioned, it is not FDA approved, and ranibizumab, it has been approved for the treatment of DME. The recent advance is the presence or the use of an aflibercept or the VEGF trap molecule, which is a recombinant molecule which has high affinity for everything, for VEGF-A, B, C, D, as well as the placental growth factor 1 and 2. Now, apart from, so this is how diabetes causes diabetic retinopathy. The chronic hyperglycemia induces leukostasis, which induces the releases of multiple inflammatory mediators also causes release of VEGF, which is inhibited by the anti-VEGF agents, which we just discussed. But along with that, we also have some inflammatory mediators present, which also constitute an important role, which cause loss of retinal capillary endothelial tight junctions. They increase the vascular permeability and lead to macular edema. So to target these inflammatory mediators, we now have something known as a steroid implants, which has also recently come into the market. So a single shot of steroid, as all of you know, may cause cataract, may cause glaucoma, may cause increase in intraocular pressure. So these steroid implants are actually a sustained release implant. So these steroids work by inhibiting the leukostasis and mitigating the release of local inflammatory factors, including VEGF. So this is how it comes. It's like a pen. You just have to press the trigger button and it gets released into the eye. And this is how the steroid implant looks within the eye, looks inside the eye. So it stays within the eye for around 3 to 4 months, slowly releasing the steroid and gradually delivering the drug and decreasing the macular edema. So that obviates the need for frequent injections. Anti-VEGFs generally need to be given on a monthly basis till the edema is controlled, but steroids need to be given only once in 3 months. Now the lasers was, as I mentioned, was the gold standard initially, but now has been taken over by anti-VEGFs, but they still have a role. It's not that they are obsolete. They still have a role in proliferative diabetic retinopathy, where we do a pan-retinal photocoagulation to destroy the hypoxic retina. So this is a patient with diabetic macular edema, and this is how the patient would look after we've given laser treatment. So this is just a pictorial representation. The laser spots which actually look white, not black, as this is just a pictorial representation. Yeah, and this is another patient with a proliferative diabetic retinopathy where a pan-retinal photocoagulation has been done. So you can see these are the laser spots that have been given to the patient for the proliferative diabetic retinopathy. The last advance is in surgery. So initially it used to be a stitch, the patient had to be opened up like it was a 20 gauge surgery. So the 20 gauge means around 1.1 millimeters. So the patient had to be sutured after the surgery, the sclera had to be sutured. But now what we do is a very minimal invasive surgery, what we know as a micro incision vitrectomy system, which is a 25 gauge surgery, which is as small as 0.7 millimeters. So the patient comes out of the surgery sutureless. There is no stitch involved. And this is a minimally invasive vitrectomy system. You can see that there are 3 ports here for the surgery. And it is like you can say it's like an endoscopic surgery where you have a light which goes in and the cutter which goes in. And this is to maintain the infusion inside the eye. And this is a major advance that we have now very, very minimum gauge surgeries like 25 gauge, 27 and even 29 gauge, which have shown equally good results, and because of the improved instrumentation there are less complications as well. So diabetic retinopathy showed that early vitrectomy within 6 months is more useful, especially for type 1 diabetics. Early surgery with PRP provides, that is pan-retinal photocoagulation, provides better visual results, and anti-VEGF agents have proven useful in the management of vitreous hemorrhage. So that's the end of my presentation. Thank you so much for your patient listening, and thank you once again, Dr. Sabeer, for giving me this opportunity.
Thank you, Anusha. That has been an excellent, comprehensive, crystal clear, energetic, and enlightening presentation. We come to the last topic of Diabetes Today 2020, and the presenter now is none other than the backbone, brain, skeleton, flesh, and blood of Diabetes Today 2020, Dr. Sabeer A Rasheed, who is the Chief Consultant and Director of the Rasheed Speciality Center and Managing Trustee of TDRF. And the topic is novel pharmacotherapy for obesity. Over to you, Dr. Sabeer.
I just want the opinion from few of my friends. Balash and Valued sir is there, Sunil is there, Arun is there. I can see few faces. How is the overall experience, Dr. Arun? Can you just mention in few words?
It has been brilliant. The online conference has been brilliant. Brilliant selection of topics and speakers. The only suggestion is that it would be great if we can keep some more time for certain vital sessions. Like, for example, the session on vitamin D and vitamin B12, I felt it should have received a little bit more time. Also, the exercise session by Dr. Roy R. Chandran should have been an extensive workshop mode, should have received a little bit more time. And also the ophthalmology session by Dr. Anusha, and a session on insulin also, the practical tips regarding that. We could have given a little bit more time and converted them into workshop models. It would have been much more practically useful for the clinicians. That's the only suggestion. Other than that, it was a brilliant experience.
Okay, perfect. So, Dr. Balakrishna sir is there. Do you have any comments, sir?
It's a pleasure to see that you have organized such a great CAP during this. As I mentioned in my sharing session, there are a lot of adversity which is running in your state. But in spite of that, we don't have much of a technical hitches in the audio, video, and all. I expected that being in the northern part of Kerala, it will be difficult for me to interact and hear. But the audio and other system is very good, and I may be able to hear all the speakers very well. And again, I think that probably you can incorporate a little bit of posters in between show, in between the hall and other things in the next time, so that you incorporate a little of junior doctors also. Because in a virtual meeting, it is also possible. Some posters or some other things, or some, as I've mentioned earlier, some workshop-like things can also be incorporated in this. That is what I think. It will make it a more useful for everybody.
Okay, sir. Thank you. Thank you. Welcome.
Really a great congratulations for you and your team.
Okay, sir. Thank you. And Dr. Sunil, are you there? Sunil?
Yes, Sabeer. I think
Just few words.
Sabeer, actually, first of all, let me extend my Sabeer, because so many universities, the day before, I think we were really surprised and we were really happy in Kerala. Despite this, nobody would have dared to go for such a venture. But after seeing 2 days, I think we couldn't have asked for a better CME in the present context, because as everyone told, he dared to go for such a venture, and I think most of the sessions were good, excellent speakers, excellent, and we couldn't have asked for one in the present context. All congratulations to Sabeer, and I'm sure that he will make up the hitches this time around, and surely he will come up with a better show than this next time around. Over to you, Sabeer.
Thank you, Sunil. So we'll move straight away into the topic proper. I think we have crossed the time. It's around 6 p.m. So we have to wind up in few minutes. So I will be just running through the slides. This is something regarding the newer pharmacological agents for obesity management. So what exactly is the obesity? Actually, is it a disease or is it just a terminology? So we all know that this obesity is disease of the civilized society. So we have to find out whether obesity is really a disease. The American Medical Association in 2013 declared obesity as a disease in its resolution 420, stating that it recognizes obesity as a disease state with multiple pathophysiological aspects requiring a range of interventions to advance obesity treatment and prevention. So what is the prevalence? We can have some few information regarding the prevalence of obesity both globally and in our nation. Globally, obesity has nearly tripled since 1975. And by the census of 2016, more than 1.9 billion adults over 18 years were found to be overweight or obese. In India, 13 to 50% of the urban population and almost nearly 35% of the rural population suffers from obesity. And obesity, that's an interesting finding. Obesity is commonly seen in women compared to men and is increasing in children and adolescents. And the state of Punjab in India, when compared to other states, state of Punjab has the highest prevalence of obesity Just 1 second. 1 second. Struck. Okay, so this is the state-wise survey of obesity in Indian states. Top the list with Punjab, then followed by Kerala, then Goa, Tamil Nadu. So the southernmost states, I think the level of obesity percentage is more compared to other states. So adult is a person who has stopped growing at his ends and is now growing in the middle. So, as per the Dr. E.P. Jocelyn, the father of diabetes, from an excess of fat, diabetes begins, and from an excess of fat, diabetics die too. So, how can we tackle this global issue, this obesity? We have many traditional weight loss therapies. As we all know, we have multiple options ranging from nutritional therapy, physical activity, behavioral therapy, pharmacotherapy, bariatric therapy, etc., etc. All these have to be individualized accordingly as per the suit of individual. So I'm not going to the details of lifestyle modification and all, because our topic is concentrated on pharmacological agents. So as per Time Magazine, the best way to combat obesity is to build up your biceps in order to push yourself away from the dining table. Definitely, lifestyle modification is a major role or major part of obesity management. So diet, definitely, I'm not going to the details. All these sort of junk foods can definitely lead on to obesity and further lead to complications of obesity like cardiovascular and cerebrovascular. So many, I'm not going to the details. And this is a cartoon showing if we take the starring food like this junk foods and all, instead of mummy returns, the actual happening is that tummy returns. So we have to be careful. Definitely exercise is more important than diet in controlling obesity. So coming to the topic of pharmacotherapy, we have, I'm just going to the timeline of anti-obesity medications. Before 1900, actually the thyroid hormone preparations were used as anti-obesity drugs, because when the hypothyroid patients start consuming thyroid hormone preparation, they found to lose weight, lose some minute weight and all. So they thought that thyroid hormone preparations were actually anti-obesity drugs, and initially, in the early 1900s and all, they were using thyroid hormone preparations as anti-obesity drugs. Then that concept was discontinued. Then came dinitrophenol, because of the process of this preparation of dinitrophenol, it caused weight loss by generating heat. Again, it also discovered. In the early 1930s and all, first amphetamines were introduced, and it served as anti-obesity agent. Then in the late 1950s, FDA has given approval to phentermine as an appetite suppressant and anti-obesity drug. Then came early 1990s, combination of fenfluramine and phentermine, then sibutramine, and not going to the details. Then came orlistat, rimonabant, and last lorcaserin and fusamia. So, but unfortunately, most of them were banned by FDA due to their potent side effects. So all this, I'm just next. I think almost all these drugs, in one way or other, has been banned by the most of the official organization like FDA or EMA, etc., including sibutramine, rimonabant, amphetamines, etc. So coming to fenfen, formerly known as fenfen, the combination of fenfluramine and phentermine. Fenfluramine, a serotonin agonist, when combined with phentermine, a dopaminergic agonist, was found to be effective in weight loss management, but was withdrawn from the market due to its potency in inducing valvular heart disease and pulmonary hypertension. Then came rimonabant by Sanofi by the name Acambila. It blocks the cellular receptor in the endocannabinoid system of the brain, believed to have significant role in the appetite drive, thereby reducing body weight. It was earlier approved by EMA in 2006. But in 2008, EMA recommended the suspension of Acambila due to its potency in inducing severe depressive disorders and increased suicidal tendencies. And FDA never approved rimonabant as an anti-obesity drug. The adverse event problems linked to rimonabant and its ultimate suspension have resulted in the termination of the clinical development of 3 other cannabinoid CB1 receptor antagonists named Merck's taranabant, Pfizer's otinabant, and Bristol Myers, it has not named. So all these 3 cannabinoid receptor development has been banned because of the adverse issues reported with the parent molecule. Then came sibutramine by the name Verdia by Abbott. It's a centrally acting serotonin norepinephrine reuptake inhibitor, thereby increasing the levels of the substances and helping enhance satiety. But unfortunately, in 2010, both FDA and EMA voted against this in view of its potency to increase the risk of cardiovascular events and cerebrovascular events. So right now, we have only 6 major class of medications approved by FDA as anti-obesity medications. First one is phentermine, then orlistat, then phentermine topiramate, then again combination, lorcaserin, and naltrexone bupropion combination, and finally liraglutide or Victoza or GLP-1 analog at a higher dose of 3 milligrams. So these are the only 6 class of medications which are available as anti-obesity drugs approved by FDA right now. So I've already gone through this slide. So coming to all these 6 molecules one by one, Orlistat, it's only known as Senecal by Roche. It's a saturated derivative of Lifstatin, a potent natural inhibitor of pancreatic and gastric lipases. When administered with foods, Orlistat inhibits the hydrolysis of triglycerides, thereby reducing the subsequent absorption of monoglycerides and free fatty acids, leading to a reduced fat absorption by around 30%. So again, so many reported adverse events with Orlistat, starting from oily spotting, flat, oily stool, fecal incontinence, etc., etc., etc. So Orlistat prescribing information is it has to be taken 120 milligram twice daily along with main meals, at least with main meals. And Orlistat is contraindicated for pregnancy and pregnant and lactating women, and those with chronic malabsorption syndromes or cholestasis. And mind you, there's a caution in using Orlistat because concerns about a link between Orlistat and colon cancer is being investigated. And in May 2010, FDA has approved a revised label for Orlistat to include cases of hepatic injury with the use of this medication. So we have to be very careful and prescribe this medication, especially to our diabetic patients. Then came Lorcaserin, name was Belvic by Arena Pharmaceuticals. It's a selective serotonin receptor agonist. It's a selective serotonin receptor agonist and thereby reduce hunger by the production of opiomelanocortin neurons in the hypothalamus. And after repeated rejections by FDA in view of its less efficacy and potent side effects, was finally approved in May 2012. And the FDA has requested for a post-approval trial to assess the long-term cardiovascular effects of Lorcaserin. And it's available in India by the name Afens by Sun Pharmaceuticals. Next, combination of topiramate and phentermine by the name Fusaimia by Vivus Pharmaceuticals. Actually, the combination of topiramate and phentermine, topiramate is actually an anticonvulsant. When combined with phentermine and appetite suppressant, was found effective in weight loss management. Approved by FDA in 2012, but not by EMA as it was related to suicidal thoughts and birth defects. Studies are in favor of its use in diabetes and also in obstructive sleep apnea also. Again, so it's a study supporting the use of topiramate and phentermine. I'm not going to that. Another combination, interesting combination is sonisamide and bupropion by the name Empathic by Oregon Therapeutics. It's a new generation anti-epileptic sonisamide when combined with bupropion, an atypical antidepressant is found effective in weight loss management. This is a study supporting the combination therapy. Next came another good combination, naltrexone and bupropion by the name Condrave. A combination of naltrexone 32 milligram and bupropion 360 milligram was approved by FDA as an anti-obesity drug. But the concerns are there with this combination also because of the psychiatric side effects and the propensity to elicit depressive disorders. So currently undergoing late phase safety trials to assess its cardiovascular complications as such. So anti-obesity drugs which are clinically under pipeline, we have n number of molecules starting from Setlistad, Cunexia, Tisofensine, Condox. We will just discuss a couple of drugs. So Setlistad by Takeda and Alizine, it's almost similar to Orlistat, which we have already discussed. This is the same class of medication. It's a pancreatic lipase inhibitor and similar action like Orlistat. Completed almost phase 3 trial. I think it's almost into the market, and in certain countries and certain areas already there, and the physicians are prescribing the Setlistad as anti-obesity drug. Tisofensine, it's an interesting molecule by neuroresearch. It's a triple reuptake inhibitor. It's a serotonin, noradrenaline, and dopamine reuptake inhibitor. Originally investigated for the treatment of Alzheimer's and Parkinsonism, but the results were in supportive for weight loss therapy. So it was designed as an anti-obesity drug. It's almost completed phase 2 trials and was published in the Lancet and shows that almost weight loss over a period of 6 months of more than 12 kilograms with this wonderful molecule. So, but since this tisofensine is a triple reuptake inhibitor and tisofensine share pharmacological properties with the sibutramine, so has the potential to increase heart rate, blood pressure, and psychiatric disorder. So the safety issue has to be taken into consideration. So another interesting molecule in the pipeline is eslopitant. It's a neurokinin receptor antagonist initially investigated for irritable bowel syndrome and for emesis induced by chemotherapy, but since studies suggest it can reduce the appetite for sucrose and hence decrease the, and it's interesting is that studies suggest that it can reduce the appetite for sucrose and hence decrease the consumption of sweetened foods and drinks. So this is an interesting feature of this molecule. This just completed a trial in animals only, so may take years to reach the market. Another wonderful molecule is beloranib by Samsung Pharmaceutical. It's actually an analog of the natural chemical compound fumagillin and originally designed as an angiogenesis inhibitor for the treatment of cancer, and clinical focus shifted to anti-obesity therapeutics once potential effect was realized. And in December 2015, unfortunately, phase 3 trial of beloranib was discontinued after a second patient death and thereby obstacles for getting FDA approval for this drug. Again, another interesting molecule is setmelanotide by Rhythm Pharmaceuticals. It's a selective melanocortin 4 receptor agonist. Regulate food intake and satiety. This is associated with small increase in plasma fasting glucose. So have to be careful in prescribing diabetic patient. Currently, also this is also molecule is also being evaluated for rare genetic disorders such as Prader-Willi and Prader-Willi syndrome, etc. And valniparin is a neuropeptide Y5 receptor antagonist. It decreases the hunger and increase satiety, and originally developed by Shionogi as an anti-obesity drug due to its anorectic effects, but recently again discontinued with the further development after disappointing results showing modest weight loss in phase 2 trials. And again, the Shionogi, they are trying to combine this valniparin with orlistat as an anti-obesity drug. So this molecule, I think everybody might be knowing, pramlintide by the name Cimalin by AstraZeneca. It's an amylin mimetic, aids in the regulation of blood glucose, also delays gastric emptying and promoting satiety, thereby cause weight loss. And approved by FDA for use in type 1 and type 2 diabetic patients along with insulin. And diamlitide, an amylin mimetic peptide, has demonstrated in animal studies to reduce food intake and body weight with enhanced metabolic activity. So next, the last slide is Saxenda, it's a GLP-1 analog. We all know liraglutide for the use of diabetes. We are using this liraglutide by the name Victoza at a higher from 0.6 to 1.8 milligram daily. At a higher dose of 3 milligram, FDA has given approval for this liraglutide as an anti-obesity drug, and this is named as Saxenda. But unfortunately, I think Novo Nordisk has not yet launched this drug in our market, maybe because of the cost effect. So thank you very much for the patient listening. So any comments, or since we are running short of time, I think we will conclude the session and
thank you, Dr. Shabi, for that extremely comprehensive presentation.
Sabeer, one comment.
Yes, please.
Regarding sibutramine, I think we had conducted a study on in 2008 to 2010 using sibutramine. Yeah.
Okay.
Almost 600 patients were studied in two groups, and it is shown that almost 5 to 6 kg loss was there in 80% of patients. But unfortunately, by the end of the study, the drug was banned. Unfortunately. Actually, that is a very, very useful drug. We don't come across any of the side effects, they say, like suicidal tendencies or increased CVD. But that was banned, unfortunately. That is a wonder drug. Did anyone use that molecule? Other experience with sibutramine? Orlistat definitely is a failure because we won't take fat as high as 60% like Westerners. Our fat consumption is only 20 to 30% in India.
Another issue with the anti-obesity drugs are that if we stop the drug, what could be the weight gain and other thing is an issue of concern. So long-term use of most of these drugs may not be of much use.
But with almost I think almost 50% have got remission rate with proper lifestyle modifications. Very effective in reducing the initial weight, sir. Sir.
I think it's easy to reduce the initial 5% weight in our patient with whatever.
If you continue the lifestyle modification, we can keep the remissions.
But efficacy of drugs and continuing drugs, that is a concern. I think there is some horoscope problem with all the drugs which has been launched as anti-obesity.
Yes, sir. Yes, sir.
Okay.
Okay, if there are more questions. Any more questions? There are no more questions. We can wind up the session. Thank you very much for the excellent lectures. And thank you very much for the wonderful discussion points raised by Dr. Roy and Dr. Balakrishnan as well. And once again, my sincere gratitude to TDRF and Dr. Sabeer for giving me this great opportunity to chair this session. So over to the organizers for the concluding remarks and for the valedictory function.
To give the vote of thanks, I would like to welcome Dr. Sabeer A Rasheed.
Seems to be some connection problem at Dr. Sabeer's end.
Yeah. Some technical issue is there. Is it audible now?
Yes, very much.
But still there is some issue. Let me see. Okay, this is the main issue of such digital summits.
I think, Sabeer,
yes.
If everyone could switch on their video, it would be a good thing.
Okay. I request all the faculty members or those who have assembled here can switch on their video, but try to mute your audio. But everyone can switch on their video. Yeah, Sibisar is there. Rajesh is there. I can see few of their faces. Yeah, Jacob is there. Shubhashri is there. Yeah, I can see few of the faces. Okay, still Sunil, am I still audible? Yeah, Dr. Roy is there. Hi, Roy. Fine. So slowly, one by one, is switching on the videos. Good. Actually, Sibis sir, are you doing treadmill exercise? Okay. Anusha is there. Good. Manikandan is there. So, without wasting much time, I think we will have the vote of thanks now. So, as we near the culmination of Diabetes Today 2020, I stand here in front of you with a great sense of fulfillment and a heart full of gratitudes to each and every one of you in making this. And hi Arun Gobi, making this humble event a great success. Actually, it was for the first time that we had to organize our update in an online format, and we at TDRF understandably had our apprehensions initially regarding how it would be received because of the increased number of webinars floating around every day in this COVID era. But I am extremely delighted to say that all our fears were melted on day one itself by the quality of the lectures, the enthusiastic participation from delegates, and the awesome feedbacks which we kept in receiving following session after session. As the time to draw curtains for Diabetes Today 2020, I would like to express my sincere gratitude to all faculty members and chairpersons whose amazing performance made this update an academically enlightening and extremely lively experience. I also express my heartfelt thanks to all the delegates for assembling over here, for registering and to listen throughout the the duration was almost around 36 hours. So I had expressed my heartfelt thanks to all the delegates. My words of appreciation for pharma friends are also there, who played a significant role in making this a reality. And finally, to my team TDRF and the organizing committee, especially Dr. Sunil Prashok, who was there with me throughout the event, Dr. Arun B. Nair, my very close friend, Dr. Deepa, again, who contributed significantly for the event. I also thank my staff members, especially Mr. Harikrishnan, Midala Mahendran, Divya, and team led by them, without whom the event may not be a success at all. Last but not the least, I express my word of thanks to Mr. Praveen from Oxysia Pharma for the technical support given, and also to the Even Guru firm for the complete web support. They have wonderful web support they have given throughout from the day one, first minute itself. Mr. Rajildas was from Even Guru. He just traveled from Cochin to Trivandrum in this COVID time, and he stayed along with us for throughout this all 3 days, and he was with us for conducting this program. And so I sincerely hope that we would be able to meet face to face in 2021 for our 5th annual update of Diabetes Today 2021. And I hear myself signing off from Diabetes Today 2020 as organizing chairperson of the program. So since we are all here, we will just, thank you. We are all here. Okay. Thank you. Thank you. Okay. So thank you very much for our. So we will stand up for a moment for a
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे ताहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे